All right, let's dive into one of the trickiest areas in all of radiology, the temporal bone. We're going to do a rapid, high-yield tour of the mimics and showdowns you are guaranteed to face. Think of this as your cheat sheet for that tough case or that late-night on-call read. So, picture this. It's 2 a.m., you're on call, and this scan pops up. You've got an enhancing lesion smack in the middle of the petrous apex. Is it a nasty tumor, or is it just some weird-looking fat? The call you make next could change absolutely everything for this patient. It really shows you just how high the stakes are in this tiny, super complex piece of anatomy. So here's our game plan. We're going to start from the outside of the ear and work our way in, hitting the biggest diagnostic headaches in each spot. We'll cover infections, inflammation, some really interesting congenital stuff, and we'll wrap it all up with a lightning round on trauma. Okay, first up, the external canal. This is where we run into our first classic this versus that showdown. We're talking about a really dangerous infection squaring off against a totally benign bony overgrowth. And you can see right away the patient profiles are like night and day. On one side, you have necrotizing otitis externa. This is a nasty, aggressive, bone-eating infection caused by Pseudomonas, and you almost exclusively see it in diabetic patients. On the other side, exostosis. It's often called surfer's ear because it's from chronic cold water irritation. One is a true medical emergency. The other is, well, basically just a bony callus. Let's dive a little deeper into the middle ear. This is home to one of the most important mimics you have got to master, the Cholesteatoma. This thing is a master of disguise, and trust me, it can cause some major destruction.
You know, the easiest way to think about a cholesteatoma is that it's just skin, but it's in the wrong place. But don't let that fool you. This isn't some harmless little cyst. It's an inflammatory, erosive machine that acts like a tumor, literally chewing through all those delicate little bones in the middle ear.
So what's its main lookalike? Chronic otitis media. Both of them can fill the middle ear with what looks like soft tissue, but the huge difference is what that tissue is doing. Is it just some passive fluid and gunk from an infection, or is it an active, destructive, erosive mass? And the number one giveaway is bone erosion. Just look at the chart. With a cholesteatoma, erosion of those tiny hearing bones, the ossicles, or the scutum is super common. We're talking about 75% of cases. But with simple chronic otitis media, it's really rare, less than 10%. So here's the rule. If you see bone being eaten away, cholesteatoma has to be at the very top of your list.
Okay, heading even further in to the inner ear. The game changes here. We're not talking about masses so much as things that directly mess with our most critical senses, hearing and balance. So we're going to look at both nerve function and what happens when things don't form right in the first place.
The facial nerve is super tricky, and this is a classic resident pitfall, because parts of it are actually supposed to enhance. See here, the tympanic and mastoid segments? Yeah, they can light up normally, no big deal. But the real red flag is when you see enhancement in the canalicular segment, inside the internal auditory canal. That's the abnormal finding that should make you think of something like Bell's palsy.
Now, let's talk about congenital hearing loss. It's best to think of it as a spectrum, right? The earlier in development that something goes wrong, the worse the outcome is going to be. So let's compare two conditions from opposite ends of that spectrum, Mondini malformation and Mischel aplasia. And here's the breakdown. Mondini is an error that happens late in the game, around the 7th week. What you get is a cochlea with only 1.5 turns instead of the normal 2.5. This usually leads to significant but often partial hearing loss. Mischel aplasia, on the other hand, whoa, that's a problem from way back in the 3rd week of development. The result? A complete absence of all inner ear structures. The clinical bottom line is devastating: total deafness. All right, welcome to the boss level, the petrous apex. This tiny little spot is just jam-packed with critical stuff, and the lookalikes here can lead to some absolutely devastating consequences if you get them wrong. So let's start with the two heavy hitters here. On one hand, you've got the cholesterol granuloma. This thing is basically an expanding ball of cholesterol crystals and old blood, and its signature move is being intrinsically bright on T1-weighted images. A cholesteatoma here is the polar opposite. It's T1 dark, and here's the clincher. It will show restricted diffusion. So why do we care so much about telling these two apart? Because they threaten the patient in totally different ways. A missed cholesterol granuloma will just slowly get bigger, pushing on nerves and causing hearing loss. But a missed cholesteatoma, that can aggressively eat its way right into the brain, leading to life-threatening stuff like meningitis. So let's go back to our 2 a.m. question. How do you tell that T1 bright granuloma from just normal marrow fat? The answer is simple. Use a fat saturation sequence. Normal fat will suppress, it'll go dark. But that cholesterol granuloma with all its blood products, it will stay stubbornly bright. It is such a simple trick, but it solves a huge, huge problem.
Let's hit another big mimic in the apex. The patient comes in complaining they can hear their own pulse, whump, 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 in their ear. The surgeon looks in and sees a red pulsing mass behind the eardrum. Now, you might be thinking vascular tumor, but there is one thing you have to rule out first, because if you biopsy it, it would be an absolute catastrophe.
In that classic do not biopsy lesion is an aberrant internal carotid artery. This is a developmental variant where the carotid artery decides to take an abnormal shortcut right through the middle ear space. It is not a tumor, it's the patient's own major blood supply to the brain, just running through the wrong neighborhood.
So how do you nail the diagnosis and stop that dangerous biopsy before it happens? You look for one thing, and one thing only. Can you trace that vessel in the middle ear directly to the horizontal segment of the carotid canal? If you can show that connection, you've proven it's an aberrant ICA. Case closed. All right, for our last section, let's switch gears into a rapid-fire trauma review. These are the high-yield fracture patterns that you absolutely need to have locked in for your exams and for any trauma read you do. First on the list, the LeFort fractures. These are the 3 classic patterns of mid-face fractures. They're actually named after René LeFort, who, and this is a bit grim, figured out these predictable lines of weakness by doing experiments on cadaver heads. Let's lock these in with some buzzwords. A LeFort I, that gives you a floating palate. A LeFort II is that classic pyramidal face fracture. And a LeFort III is the big one, craniofacial disjunction, where the face literally separates from the skull. But here's the one thing you absolutely cannot forget, the key feature for your boards. The pterygoid plates are fractured in all 3 types. And that pretty much wraps us up. Look, I know it's a lot, but if there's one thing to take away, it's this. The temporal bone is a land of millimeters. The distance between normal hearing and total deafness, or between a working facial nerve and permanent paralysis, can be smaller than a single pixel on your screen. Every single one counts.